So once again, welcome everyone who's joined us today for the last session of our seminar season. I'm Tamar Austin here with the Birthplace Lab. And today we have Dr. Cristina Alonso from the Massachusetts Department of Public Health, who will be presenting on implementing the maternal health law in Massachusetts. So Dr. Cristina Alonso serves as Division Director for Pregnancy, Infancy, and Early Childhood at the Massachusetts Department of Public Health. Dr. Alonso is a doctor of public health and a certified professional midwife who has ample experiences implementing system changes in complex political settings. Prior to moving to Massachusetts, Dr. Alonso worked for 2 decades in Latin America, improving the quality of care in maternal health and integrating the midwifery model of care. She founded several full-scope birth centers in Mexico and worked with the Mexican Ministry of Health to integrate midwifery into the healthcare system. Dr. Alonso was also an intern here at the Birthplace Lab in the summer of 2019. So today she'll be explaining the key provisions of the Massachusetts Maternal Health Law, describing the role of Massachusetts Department of Public Health in the law's implementation, and also assessing the impact of the maternal health law, as well as the challenges of implementation. So without further ado, I'll pass it on to Dr. Alonso.
Thank you so much, Tamar, and thank you everybody at the Birthplace Lab. It's wonderful to be here. I'm really grateful for the invitation and really grateful for all of you who've taken your afternoon to come listen to this. I'm sitting in Boston, which is territory that was taken from the Massachusetts and the Wampanoag tribes. And my pronouns are she, her. And today I'm going to be talking to you about, from the government perspective, how we're taking on the implementation of the maternal health law. Some of you might have been at the presentation in December where the community partners who actually got this law passed across the finish line, how they managed to do that and all the work that the community partners did to get this law actually into stature. And it was passed in August of 2024. And really it's a momnibus. We call it a momnibus because it's incredibly complex. It has many, many provisions. We won't be able to talk about all of them today. And really what I want to focus or kind of give you some insight on is what it feels like to be within the government and to receive this bill on your desk at the end of August and say, okay, go, do it. So that's what we'll be talking about. I will try to talk slowly. Those of you who know me know that I don't, but I do appreciate that we are interpreting. So I'm trying to look out for my colleagues who are helping the Spanish speakers. And saludos to all the compañeras from Mexico. It's great to see you guys here. So just a quick overview of what we're going to be talking about today. I'm going to talk to you about the bureau in which I work, which is the Bureau of Family Health and Nutrition. We'll talk about the maternal health law. We've selected 5 aspects of the law to deep dive into. These are only 5 of many, many details. So if you have questions about other pieces of the law, or if you have questions about, what about this thing that's really important in maternal health, well, we can talk about it during the question and answer period. All right, so the Department of Public Health Bureau of Family Health and Nutrition is one of 8 bureaus in the Department of Public Health. And really what we're looking at is the spectrum of needs across the perinatal period and childhood and growth. And so we do both research and implementation, and we do that through several divisions actually, and one office. So our divisions, we have 6 divisions, and each one of them takes a little piece of the complexity of pregnancy, birth, child development, also recognizing that we do a lot of overlap work. So of course, nutrition affects everything. So it's really hard to make clear boundaries. But the division that I'm charged with is the Division of Pregnancy, Infancy, and Early Childhood. And what we do is oversee the implementation of programs that have to do with pregnancy, birth, postpartum, and up to 8 years old in children. So let's talk about the maternal health law. Chapter 186 of 2024 is an act promoting access to midwifery care and out-of-hospital birth options. And really, the goal of this birth was to strengthen maternal health practices and expand coverage for services, including midwifery, birth centers, doulas, screening, treatment for postpartum depression, and birthing and pregnant families in Massachusetts. So there's parts of the bill that actually refer to reimbursement. And some of that is reimbursement specifically to our Medicaid, which is our public payer in the United States. And some of that, in every state has its own Medicaid office, and ours is Mass Health. And I see that Sarah Krinsky from Mass Health is here today. Hello, Sarah. And we also, many of you know that the US is a combined system. So there's also private payers, which is the private insurance companies. So about 40% of people in Massachusetts have their births paid for by the public insurance system, and about 60% have it paid for by private insurance products. So some of the maternal health law refers to just Mass Health reimbursement, and some of it refers to all payers. The other parts of the law refer to regulation, and that's specifically what the Department of Public Health does. We regulate healthcare facilities and we regulate healthcare providers. So there's a lot in the bill that talks about different, specifically it talks about certified professional midwives, but it also talks about birth centers. And it also talks about doulas. I will mention that in Massachusetts, Mass Health, our Medicaid provider, started reimbursing doulas in January of 2024. So this law actually, they started doing it, but this codifies that reimbursement. And then the other piece of the other sort of third bucket of the law is really about funding community engagement. So strengthening the community capacity to deal with birth, pregnancy, and postpartum. And we know, all of you that are here know this, that birth and pregnancy, birth, and postpartum happen in the community. You don't spend much time in a hospital or a birth center. You're really in the community. So that's where, if we're going to improve outcomes and improve equity, we really need to strengthen the community. All right. So I'm going to break down the bill a little bit and tell you about how we've been. Hang on, my Zoom is telling me something. Oh, all right. Just to kind of a quick overview of aspects of the bill that we've completed and not completed, and where are we with these things. So we completed the birth center regulations review. So just to give you some background on that, basically the way that the birth center regulations were written before this law was that they were very restricted and that they required signed transfer agreements with hospitals. The medical director needed to have privileges at a hospital. The facility regulations had to attend to federal facility regulations. And so it really made it difficult for birth centers to operate as birth centers, and therefore made it very difficult to open. So this didn't start in August. We've spent several years now engaging with the community to try to write regulations that are actually relevant to birth centers and are designed based on the American Birth Center, the American Association of Birth Center, and their accreditation council, those recommendations, so that birth centers are birth centers and are regulated as birth centers. So those regulations were approved in February. We have one birth center in the state. This is very important to understand. Two alongside birth centers closed down during the pandemic. They were part of hospitals and they were shut down. And to date, we don't have more freestanding birth centers open yet, but I also see that Rachel is on the call, and hopefully we'll be having some more coming soon. More on that later. It expands authority of the Maternal Mortality and Morbidity Committee. So one of the issues that we had with the Maternal Morbidity Committee was issues around transparency, access to records, and different records across the course of care of the pregnant person that might have died. And so this law was very prescriptive about what needed to be expanded in the authority, and I'll talk about that in a minute. We've completed both of those tasks, and I'll say that those were tasks that had to do with writing laws and getting our legal team engaged, and so that was able to happen pretty quickly. I will say that the timing, and I'm going to combine implementation successes with challenges at the same time, because these things kind of work together all the time. The fact that this bill was signed in August of 2024 gave us time to get things done before January 20th of 2025, which is a historic date in the history of the US, where our legal teams suddenly had to deal with other pressing issues, and are less able and less nimble to attend to the internal legal issues that we're having within DPH, such as approving laws and that sort of thing. And we can talk more about that later. But Massachusetts has been involved in suing the federal government on several tasks, so it's been additional work for our legal teams. The bill establishes a maternal health task force with the Health Policy Commission, and really the mandate of this task force is to look at maternity care closures, both hospitals and birth centers. Why are they closing? What's going on? What happens to the community once these close? And I actually spent most of the afternoon today on the Maternal Health Task Force meeting, where we're tasked with completing a report for the legislator, understanding why these closures are happening, and writing a series of recommendations on what we can do to prevent them. And there's issues, obviously, both finance and regulatory and workforce and all of that. But the point of this report is to have a deeper dive into what can we do differently. It also calls for a pregnancy loss information campaign. I will state that abortion is legal in Massachusetts, and it is we do have shield laws in Massachusetts as well. It also calls for I have to move my computer because I have screen on screen. It calls for a digital resource center for perinatal and mood and anxiety disorders. This is important because almost half of our maternal deaths in Massachusetts are related to pregnancy, mood, anxiety disorders, and substance use. So until we really start tackling this issue, we're not going to see an impact in the postpartum period and how people are doing in postpartum. And then it addresses certified professional midwife regulations. And I will spend quite a bit of time talking about that until now. And I will say now because CPMs are still not regulated. We're in process, but until now, Massachusetts is one of 15 states that does not acknowledge certified professional midwives as licensed providers. And so they can't be reimbursed, which means that people have to pay out of pocket approximately between $4,000 and $7,000 for a birth, which can be quite steep for many people, of course. It also expands a universal home visiting program. So in the US, we do have home visiting programs for different types of populations, different situations. So for example, families under 23, or we have different federal grants to support families in their homes. And we have piloted this home visiting one-time visit in 7 communities here in Massachusetts. It's working quite well. And so this bill calls for the expansion of the Welcome Family Home Visiting Program. It also expands newborn screening recommendations. I really won't get into that because neonatal is not my specialty. It talks about providing a license to lactation consultants, and this is based on the IBCLC licensure. It establishes a fetal and infant mortality review program, so looking into that, and also quality guidelines for the use of donor milk. So we want donor milk to be accessible to, again, the law is very prescriptive, babies that are in hospital and whose parent is unable to provide breast milk, and babies, of course, under 6 months of age. And it also establishes a grant program to address perinatal mental health and substance use disorders. This has not been started because it hasn't been funded. And I'd say that the biggest challenge of this bill is that it was not funded. So the bill was signed into law and it came with $0, which means that all of us that are working on the bill didn't get any extra staff. We didn't get any extra funding to be able to implement the program. And I'd say that it's not the biggest problem, but it is a very big problem in that our legislative cycle, it comes after our financing cycle. So once a law is passed, then you probably have to wait at least a year until that law can be funded. And we have laws, of course, that have never been funded, which makes implementation very, very difficult. And it relies on the goodwill of people that are just really excited to do this. The good news is that we all know that definitely in the home birth community, in the midwifery community, in the early child community, people are usually all hands on deck and really excited to expand access to care. So we do have a lot of support from people. All right, so let's take a deep dive into birth center regulations. As I said before, the previous regulations were pretty restrictive, and they were pretty much kind of based on a model that, you needed to be overseen by a physician and a hospital. And what we did was we did about a 2-year process where we reached out to community organizations, birth centers, midwives, people who wanted to have a birth at a birth center but couldn't because, of course, there weren't enough birth centers. And so we really tried to get a lot of information of what would work in terms of regulations. And then we rewrote the regulations, and then we sent them to public comment. So usually when you have a regulation, our laws require that you submit it to public comment. This is pretty typical in most governments. And so the way it works is that after we receive the public comments, we get together, both the regulatory body and myself, those of us that work in maternal health and in community maternal health, and we had to review and answer every single public comment. So why we think that's a good idea or not a good idea, and why we're going to add that or not. And we needed to be able to provide an answer to everybody that commented on the law. And I say this because a lot of the times, having worked in community for many years, our impression is, I'm not going to bother to participate in community comments. Nobody cares. The government never listens. And I really want to emphasize the importance of sending in your comments, of making that statement, of sending that letter to your legislator, to your government person, because generally there is a requirement that an answer has to be given. We know that the answer isn't always what we want, but just to remind you that conversation is important to have. So these regulations were approved. The way that they get approved is by the Public Health Council, which is basically a board that's appointed. They're voluntary, and they approved the regulations in February 2025, and they're available on our website. And basically what they say is that a birth center is a birth center, and it needs to be regulated by, it needs to look like a birth center. It needs to sort of feel like a birth center. And those that can work in it can be certified nurse midwives, professional midwives, medical doctors, and it doesn't need to be supervised by anybody else. And they don't need to have signed transfer agreements with hospitals, and they need to have clarity on who can have a baby at the birth center and when they need to be risked out. We all know that pregnancy is a process, and sometimes you have to have a consult with an MFM, and then you can bounce back into the birth center. And some people are in labor and they need to be transferred out. So we know that's always fluid. Also, it calls for an administrative director who can be pretty much anybody. It doesn't have to be a medical provider, which is also really important. Important to these regulations, this part did come with funding, which had been approved previously. So our budget had been approved in July. On the budget cycle runs 1st of July to 30th of June. And so in that budget cycle, one of our legislators, Senator Liz Miranda, who's a champion of community birth, she had secured a lot of funding for birth centers. So she had secured some earmarks for birth centers that already exist and birth centers that are in the making, and had also secured a $1 million earmark per year to distribute to freestanding birth centers. So we've been administering those grants, and hopefully those will help birth centers have some seed funding to get started. We can't have birth centers without certified professional midwives in the US. They kind of go hand in hand. And we knew that in order to open and operate birth centers, we needed more staff. And so, of course, this comes with regulating certified professional midwives. The regulation of certified professional midwives in Massachusetts has taken for as long as a CPM existed. And definitely there's a team of people that have been working on this for over a decade, and it took a lot. Massachusetts is the seat of the American Medical Association. We have really, really good hospitals in terms of, hospital publications and all of that. Mass General Hospital, the very famous Mass General Hospital, is here. So, there is the shadow of that is that the culture around birth is very interventionist and very much around go to the hospital and get great care. And we know that you get great care at home, and the best person to give you that care is a CPM or a CNM. And so the bill calls for the establishment of a board of midwifery, and this board needs to be not staffed because they're not paid, but it needs to be the people power on the board needs to be 5 certified professional midwives, 1 certified nurse midwife, 1 obstetrician, 1 maternal fetal medicine, and 1 person who gave birth. And so it's a 9-person board. The board was inaugurated in February of 2025, and they have been working hard to develop temporary licensure that will be available this summer, and also medication access. So it's absolutely essential that CPMs have access to medication. We've seen in many states what happens when they don't have access to oxygen and Pitocin and other life-saving medications. And so, again, before the bill was passed, we were already looking at what is the list of essential medications that CPMs need in order to provide care. The other thing that we did that relates both to the birth center and the CPM regulations was, and it also relates to doula integration, it relates to all of these aspects, breastfeeding, home visiting, was that as soon as the bill was passed, we developed the community birth integration strategy plan. And really what we did was we looked at what would it take to really integrate community birth as an option, and not just throwing CPMs at the system, not just opening some birth centers and hope that they work and that they don't close down in a few years, but really what would it take to change the culture around access to care and to really move the needle so that when people are thinking about where do I go to have my baby, they're not just thinking about, oh, I'll go to Mass General Hospital or Boston Medical Center. They're actually thinking about, should I have my baby at home or at a birth center or at a hospital? What level hospital? What's the right choice for me? Who do I want at my birth? All of those questions that, of course, if you're on this call, you're probably very familiar with that landscape. And so we're really looking at this as a systems change, and we've been able to secure some funding from the Pritzker Foundation, actually, to improve our engagement work with hospitals and start to build relationships with hospitals to improve transfer of care and just to improve the knowledge base of, you're going to have people coming to you saying, I want to have a home birth, or I'm planning to have a home birth. Let's integrate my hospital-based care with my home birth plan. We've engaged with Primary Maternity Care, which is an organization in the US that really focuses on drills. So drilling home to hospital transfer. So we've already conducted 4 drills in different hospitals of the state. For context, we have 39 maternity hospitals. And so our goal is over the next couple of years to do both maternal and neonatal drills, and also to establish a website where every single person, midwife, hospital can look at guidelines. So if I'm going to transfer to one hospital, what are the guidelines for transfer in that hospital? We want to be able to create resources for midwives and also a quality improvement body. So we're, looking at other states that have done this, Washington, Oregon, and look to how do you improve on transfer of care so that when it happens, which is the most, I'd say that's where we all get tripped up. When a home birth goes great, everything's great. When a hospital birth goes great, but of course the home to hospital transfer can be very painful and traumatic for the birthing person, for the community midwife, and of course for the hospital staff as well. And so we want to make sure that that is a seamless part. Other things that we're working on with this is we cannot build this up without CPM education. And we acknowledge that in the US, access to CPM education is very difficult. And so from the start, we started reaching out to community colleges. We have a robust system of community colleges in Massachusetts. And we're working with a community college in Western Massachusetts, which is the more rural, mountainous part of the state, to hopefully open a midwifery program in the next couple of years. Those midwives will need to do their practicum in the state, and that's why we're investing so heavily and trying to support birth centers so heavily so that then the students can do their practicum and we can, really build out a system of improving choice and access to community birth. All right. Switching gears, and I know this is a lot of information, so bear with me. The pregnancy loss information campaign. So the bill really requires us to look into pregnancy loss, and there's aspects of the bill that we needed to consider carefully, because in the context of the US right now with ever since Dobbs, which was a decision that was made by the US Supreme Court that gave the right to abortion back to the states. So now you may know that in up to 22 states, abortion is heavily restricted in the US. And so we wanted to make sure that anything that had to do with pregnancy loss did not look like surveillance of abortion. We want to make sure that people that want to have an abortion have access to it, and there is no surveillance about that. But we also want to recognize that people are having miscarriages, people are having stillbirths. We know that there are inequities in the number. We know that it is much more likely for a Black baby not to make it to term and not to survive childbirth. And we really want to look into that. And so for the time being, given that we have no funding for this, we have developed a website which will go live in June so this month. Our comms team are finishing that up. And really what we did on for this website was we did two parts. One was the clinical part. So we wanted to make sure that people had clarity on their clinical options, that first of all, it's legal. Secondly, you need to get help. And these are the places where you can go and get help. And the second part was the emotional aspect of this, is that we know that pregnancy loss, recurrent miscarriage, stillbirth, wherever it is, it doesn't matter if you're half an hour pregnant or 42 weeks pregnant, it is absolutely devastating. And so wanted to make sure that people are aware of the support systems that are available to them on a state level. And so what we are planning a big push in October, which is Stillbirth Prevention Month, or Stillbirth Awareness Month, really. And we're planning a series of events for October, and hopefully that will really start a tradition of us looking at this issue more deeply. We have been implementing Count the Kicks prevention campaign for several years. This is our third year. This year, we're targeting doulas as ambassadors or spokespeople for Count the Kicks. Mass Health is helping us very much with that. And Count the Kicks is an app, and it's a system where in the last trimester of your pregnancy, you're just aware of the kicks, and you just kind of get to know your baby and when they're asleep and when they're awake, so that if there's any change in those kicks, you can quickly go get care. And evidence has shown that it's pretty effective at preventing some stillbirth. So diving into the Maternal Mortality Review Committee, I mentioned at the top that so Massachusetts, I will say, reviews every single maternal death. We've been doing that. We've been able to do that for the last few years. And we've also developed a system for identifying racism in maternal mortality. And so one of the things that we kept running into was that certain bodies were not giving us access to charts. So for example, certain hospitals or police reports, or just giving us a really clear picture of what happened in that person's life and what can we do better. And the maternal mortality reports are public in Massachusetts. They're on our website. And if you ever read one of them, you'll see that about half of our mortality is in hospital, like I mentioned before, and half of our mortality is in the postpartum period. And definitely we have several studies published about the fact that in the postpartum period, pregnant people had several interactions with the hospital system, and they still ended up dying. So we're not doing a good enough job around that. And again, like any other state in the US, the disparities between Black maternal mortality and other races and ethnicities is absolutely abysmal and unacceptable. And it really looks like Black birthing people in Massachusetts are giving birth somewhere else, because the numbers are really appalling. And so we're trying to do better at that, and hopefully having better access to review. The other thing is that the law mandates more inclusion of more people on the maternal mortality committee. And we can go into the specifics of that if you're interested. And just find my cursor. And so, like I mentioned, we had piloted this universal one-time home visiting program. And really, it's an hour and a half home visiting program. Obviously, sometimes it lasts 2 hours. Maybe those of you that are home birth providers or gave birth at home are very familiar with this type of model. And there are some states that are also implementing universal home visiting services. And so the idea is that every single birthing person in Massachusetts will receive a nurse visit within the first 6 weeks of their birth. And the idea is to screen mom and baby, is everybody okay? And what do you need? And we all know that, you know, there's things you pick up on in a home visit that are not picked up on in an office visit. These nurses will be very well connected to the local system. So do you need WIC, which is our food support systems? Do you need support with domestic violence? Do you need support with, you know, childcare, whatever it is? Try to link them up and, you know, do the screenings that are mandated, such as postpartum depression. How's the baby developing? Now, what's interesting about this law is that it mandates that it be implemented universally, which means that we can't start with, so right now we're at 7 communities, so let's start with 7 and let's double that to 14, and then let's go to 28, and then let's go up, 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 up. The way that the law was written means that the 351 towns and cities of Massachusetts need to have this home visiting program available at the same time. So the complexity of building up, this is basically building up an entire division, really. We need to build up the training, the monitoring, the reporting, the reimbursement system, and the sort of networking and engagement with other community providers at the same time, and launch it at the same time. And so what's interesting about this home visiting program is that on paper, it's beautiful, it's important, and it's really necessary. Administratively, it is so complex, and it really speaks to the tension between writing a law really well and providing the system to be able to implement something really quickly and really well. So we calculate about 68,000 births in Massachusetts a year, and so we expect that we need to hire 100 full-time nurses to be able to do this work, onboard them, create a system for reporting, tap them into the larger system. So this is an incredibly complex program that needs some robust funding. And as I said, today we don't have any funding of this. So what we've focused on so far is really working with a consulting firm to design how would we build this out and what will this look like, and to really help us model the design of building this out so that we can do it well. So I'll just close with this quote, and I know that this was a lot of information, but I'm going to pause there and open it up for questions.